Very good afternoon, everyone. My name is Dr. Sai Laxman. I work as the head of the Department of Orthopaedics at the Department of Orthopaedics, KIMS Hospital's Kondapur branch. My specialty is joint replacement, especially hip and knee replacement. I do a lot of hip replacements, and we can still, in spite of doing so many hip replacements and so much of knowledge being bombarded day in, day out about the types of hips and all that. But still, there are lots and lots of people out there who have lots of doubts, and they still are apprehensive to go to a doctor. And they are mistaken for back pain or knee pain, because some of the times the hip arthritic pain is radiating to their back or to their knee, and then they are mistreated for spine and knee problems. So let us start with the basic anatomy of the hip. The hip joint has, here I can show you the basic hip model joint. The hip model has a ball, which is the head of the femur. This is a thigh bone. The thigh bone in the upper end has a ball-like ending, which is called the head of the femur, or let us say the ball. And the acetabulum or the pelvis has the reciprocating structure, which is like a cup. This is called the acetabulum. The acetabulum, I think you can see now, the acetabulum or the cup, and these two together, along with their muscles, cartilage, they become the hip joint. So now, any of these structures that are affected can cause you hip pain. It need not always be osteoarthritis. Hip pain, based on the age presentation, gives us a diagnosis in neonates, in newly born babies. Sometimes the orthopedician is called, and we go on and see that they have clicking hips. Though there is dislocation, that's what we call congenital dislocation. There is a way of treatment for that. Then once they start walking, about 2 to 3 years, the commonest hip pains that a child cannot tell, but suddenly you see that they don't, they stop walking and they have excessive crying, they are not feeding well. And then that is the time they go to the pediatrician, and then we get a referral. In those ages, between 2 to 3 age groups, 2 to 3 years of age in infancy and childhood is common for infections. Infection can be bacterial, viral, or commonest one being tuberculosis, or any other bacteria, common bacteria can cause this infection. So the treatment for that particular case is debridement. Then after that, during the next phase of growth, during the 7-8 years of age, when a child complains of a painful limb or a painless limb, the parents notice it and come to us. It could be still an infection, but then if you look at those age groups and if they are chubby and there is no history of fall, then there are two things. Developmentally, they can have what is called a Perthes disease, which is the roundness of the head becomes flatter, or the roundness of the head goes, and then because of the remolding, it does not happen proper. So sometimes they end up having arthritis, early arthritis later on in life. The other one is the epiphysis of the head. The head is not a single unit. As we grow, it becomes a single unit. The growth plate can slip off. So that is called slipped capital epiphysis. So in these conditions also, unless you recognize them and treat them early, they end up in early arthritis and requiring hip replacement at an early age. Then after that, we generally come to adult grown. After 18, once the growth is completed. So the commonest causes of arthritis in young people again, after skeletal maturity, one of the leading causes would be infection. But the most common that we see is rheumatoid arthritis. Rheumatoid arthritis is very common in ladies or women, female gender, but doesn't mean that it does not occur in men. It can happen in men also. This is one of the leading causes of hip pain or hip arthritis. Trauma. Now, once you are adult and you start driving bikes, there can be accidents, falls, and all these things. They also can lead to traumatic arthritis, fractures. These are also leading cause of hip pain. Then after adulthood, once we are into 30s, 40s, because of various reasons, let us say like a steroid use in asthma, or recently we have seen a steady increase in the number of cases post-COVID who have been using, who have used steroids for coming out of COVID. Unfortunately, have started avascular necrosis. Then alcoholism. These are a few conditions which can, excessive alcoholism especially, can lead to avascular necrosis. This also can be a lead cause for hip replacement. Then after that, age-related arthritis, of course, osteoarthritis, and it can affect any one of us with age. So these are the few conditions where you can have a hip pain. So once a hip pain occurs, then based on the type and type of the location of the pain need not always be around the hip. So that is sometimes confusing. It can be a back pain radiating into the entire leg. It can be a simple pain in the knee because the obturator nerve, which is the common supply for hip and knee. So sometimes you get the referred pain in the knee and you don't get any pain in the knee. So if you like examine the knee and take it for granted that the knee is the root cause of pain, you may have totally missed the avascular necrosis or the hip pain in the first instance. So it is very, very pertinent to examine the hip, knee, and spine of the patient whenever somebody walks into a clinic. And the basic investigations like an X-ray. And now X-ray may or may not reveal things. Majority of the times, only in advanced cases you see changes in the X-ray. So then the next modality is, if it is a pediatric age group, generally we tend to do the ultrasound. In an adult age group, we go for the MRI. So they will give us the cause of the problem. And all hip pains need not be operated. Some of them can be treated conservatively. We try to preserve the head for as long as possible. And only in the last circumstances where, in spite of all the medical treatment, in spite of rest, in spite now where now patient has come to a stage where his functional score is very, very low, he is having difficulty in activities of daily living, we generally recommend for the hip replacement. So these are that's probably I would say to some of the anatomy, the structures that are there in the hip that can lead to pain, the age groups which have more affiliation to one of either infection or arthritis kind of things. Then you have adult onset diseases like rheumatoid arthritis and all that. I'm sorry, the avascular necrosis, which can be either associated with steroid use or excessive alcoholic use, which can lead to avascular necrosis, and it can be the leading cause of hip disease. Now, based on the type of pain, when they come to the clinic, we categorize. It can be just a minor pain. And many of the times it's difficult to say whether it is radiating from the spine or from the hip, because the pain is so minor and radiological, especially on the X-ray, you can't find. Probably this is the time, rather than going for MRI, you would like to wait for a couple of weeks with medication, rest, and a few exercises. If that is not improving, probably you can order for an MRI if you have a strong suspicion that the spine is normal, still the pain is coming. Then you have a milder pain. Even in the milder varieties, you may not be able to see much changes on radiology, but significantly on examination, you'll be able to say, yes, this is not from the spine, this is definitely coming from the hip. Then we have what is called the moderate. In moderate, yes, definitely there will be changes in the X-ray. Patient will have some amount of difficulty. Probably his claudication distance, the amount he used to walk will come down by half. And basic things, he'll start feeling difficulty once in a while, requiring a tablet. And in severe cases, most of his common activities also will be affected. So once you have a hip pain, based on the type of pain, whether it could be minor, mild, moderate, severe, that's the classification. In minor and mild to moderate, probably in the first three classes, we can always treat them with conservative medication. You give them rest, you give them the proper medication, you tell them the proper exercises, you ask them to lose their weight and continue physiotherapy. But in very severe cases where the arthritis is already advanced, probably hip replacement is one of the commonest treatments or the complete treatment. There is a difference between a treatment and a cure. In a treatment, you have to treat the pain on an everyday basis. You take a tablet to reduce the pain, you avoid certain things, then you make sure that you do exercises, and then your pain is gone for today. Then tomorrow you do the same. Then the cure. So if you are not happy with this and this formula is not working, there is a permanent cure for pain relief in these conditions is the total hip replacement. Now coming to the hip replacements problem. Hip replacement is what do you do in hip replacement? If the bearing surfaces, the head of the femur and the acetabular, or the ball or the cup, they are worn, you have to replace them with artificial. So that's called a hip replacement. So in this case, let us say this is the kind of thing we are talking about. So the ball is replaced with a steel ball, or it can be a ceramic also, and it comes with a stem, which is like a pen in a refill. It goes into the femur, and then bearing surface. The other side, the establishment, the cup is also well fitted in this. I think probably from the side you can see it better, and that behaves anatomically. It behaves like the normal hip, and the muscles and the other things surrounding the hip will make you walk easily and do their normal activities and completely from pain. Now, based on the bearing surfaces and based on the method of fixation of these metals to the bone, the hip replacements are classified into what is called uncimented one and cemented ones. So cemented ones are the ones where they were first generation. We've been doing them from 1960s, and and now we have a lot of advantages and changes over the models. But the basic concept was to use a thin stem, and the gap between the stem and the canal of the femur was filled with cement. And likewise on the cup side, the gap between the acetabulum and native acetabulum and the cup also was filled with cement. So we used to use the cement for fixation. So those are called the cemented ones. Then slowly we have moved into what is called the uncimented ones. The uncimented ones are scratch fit. Scratch fit meaning you find the exact, you take the measurements, find the exact stem that fits into your canal, and then you can put the implants into it. Likewise, onto the stapler side, you find the perfect, you do a terminating surgically also, you do the intraoperative measurements and you put the cup without using. So it just goes and holds onto the cup holds onto the stapler. So this is called an uncimented. And now the most popular and the latest one being the uncimented one. The uncimented one comes with what are the surface bearings that you can choose. The commonest one and the first one available in the market was the polyethylene liner, the plastic liner on the cup side and the metal head on the femoral side. Now that was giving good results, but what was not good enough because the younger the patients were likely to have revisions and re-revisions. To avoid that, next came in the ceramic. So now you have what is called earlier we had in between we had metal and metal also because of the metallosis and other complications. Now they have been abandoned, but now we have moved on to what is called ceramic. You can use both sides ceramic or one side on the head. You can use a ceramic head on the polyethylene on the liner. You can use a polyethylene. So it's a mix and match, and the best probable results will be an hard on hard where you have ceramic on both the sides. Now the concept is to give, we are talking not in numbers, but we say that one hip, one life. So we see that if a young person for unfortunate reasons, if requires a hip replacement, we want to make sure that these hips last their lifetime. So the ceramic one is a better one. And it may or may not be a possibility if the person is very tiny. The sizes are very, very small because ceramic comes from a certain size. But once, if let us say an average gentleman requires a hip replacement, ceramic would give a lifetime of warranty. So, and then the complications. Let us talk about a little bit of the complications of the hip joint. Generally, these complications like any other things. In a slightly younger person, there is not much risk of anesthesia involved. They're all ASA grade 1. Those people with a little increased age who have diabetes, hypertension, all that, probably perioperatively or preoperatively, you should have them screened thoroughly. Make sure that they are not, because it's an elective procedure, make sure that they are not suffering from any infections already existing in the body. And then most of the times, these infections do not happen. And very rarely, once in a while, we see that these people have blood clots. This can happen to any surgery, not only hip surgery, knee surgery, abdominal surgery. Any surgery can lead to blood clots. So commonly we use either injectables or oral blood thinners. So we make sure that they do not have. And the most other commonest infection complication is infection. Infections per se, the percentage of infections are very less, but they can be disastrous. Once a pericrostic joint, like a hip or a knee, gets infected, very rarely you can get out very easily. We try with the debridement and all that, but if usually that is not the case, then you have to remove the implants, do a debridement, put in a cement spacer, use a lot of antibiotic loaded cement to cure the infection locally also, and then again go on to a reimplant, which can be quite expensive and tiresome for the patients. So these two are the main complications of any hip. And slowly over a period of time, one of the leading complications was a dislocation of the hip. Now with the advent of the newer designs, the dislocation of the hip itself has changed because the diameters of the hip and the head and the cup that we are using, they are better ones. The designs are more conforming. So the dislocation rate has come down. But that is only the implant factor. There are so many other factors. If the patient has a developmental displace, if the patient is a post-traumatic one, there is loss of bone, or the patient has poor muscles, or coming to the surgeon factor, if it is not done properly, if the alignment and the configuration is not maintained, and then if the tension in the muscles is not recreated, there is still a good chance of dislocation. Dislocations easily can be put back by giving anesthesia and putting into place. But if it is not due to a fall, let us say it is because of the global instability of it is an implant flaw, or let us say a surgeon flaw, or because of some other thing, it has to be redone again. So that was also a very leading complication. But nowadays the chance of dislocation has come down drastically. One, the techniques have improved. Two, we have better implant designs. So these are the few complications. And as such, there is not much of physio or lifelong maintenance for these kind of things. Generally, we see the patients a couple of times in a month. So once the surgery is done on the day 12, when we remove the sutures, and probably on the 21st day, until about 1.5 months later, and that's about it. And then generally we say to follow up with us once in a year, but that's about it. These exercises, simple exercises that we teach the patients, are quite good enough to take them through and build their muscles. So that's about. So I would say one of the most successful surgeries in orthopedics with the least amount of complications. And even if they have complications, which are quite amenable to redo surgeries or any of these things. And sometimes these complications can be associated with patient factors. When you do a patient selection, you have to be careful that patient are aware of they do not have musculoskeletal disorders like gait problems like Parkinsonism, or they do not have problems like Alzheimer's or forgetfulness. So these are a few conditions you have to keep in mind before doing a hip replacement. So having said that, then prevention is the best treatment. If you want to prevent hip arthritis, what are the things that you need? Yeah, steroids can be the leading cause of hip necrosis. So those have to be avoided at any cost unless they are a life-saving situation for the condition you're suffering from. Number two, alcoholism. Moderate alcoholism is fine, but excessive alcoholism can lead to osteonecrosis. Again, these are the things. In childhood or in adolescent age, infections being the commonest ones, if the parents have noticed that the child is limping or crying excessively, rather than waiting and thinking that it's a routine thing, and they can always wait for a couple of days and trying out the local remedies before going to a specialist, those sort of delays should be avoided. Wherein if you go early to that, we can either do an antibiotic suppression or do a debridement and save the hip and save them from the kids from a lot of trouble in the future. So these are the few things. Of course, trauma and the fractures, there's nothing much we can do about it. But in those cases, the first thing is you have to vary whether you need a partial replacement or a full replacement, or the hip can be salvaged in any other methods. So the actual prevention is avascular necrosis, alcoholism, and steroids. So that's the only thing that you can do. But for generalized hip arthritis, best thing is to keep your weight under control, do regular exercises. These are the ones which can delay or prevent hip arthritis. Now, I think the time is up, so probably I can stop now. Thank you.